Hey everyone, my name is Doug Rett. I'm the Chief of Optometry at VA Boston. I'm in Boston, Massachusetts. There's about a foot of snow on the ground. I hope it's warm where you are. I'll share my screen. I wanted to talk today about ocular side effects in common oral medications. I'm happy to be asked to come speak with everybody. I think it's my third Orbis webinar. I enjoy doing it. It's a global audience. I chose these medications to speak about because I think they're very common and ubiquitous worldwide, and they're very commonly prescribed. And so therefore like common side effects. But I think that the most important reason why I chose these topics is because it's an interesting mechanism of action that all of these drugs have on the eye. And I think they can teach us a lot about the eye themselves. So it's important, I think, to recognize that these drugs have these ocular side effects, but it's another thing to kind of understand the mechanism of action. So that's what we'll talk about today. There's side effects from oral medications that happen all over your body, but we have to admit that the side effects in the eye seem like they happen a little more commonly. And so why might that be? The eye is unique in several ways. In the eye, the most densely vascularized tissue exists, and that's the choriocapillaris under our maculas. In the eye, the most densely innervated part of our body exists, and that's the cornea. The eye is small, it's fragile. The eye is small, it's crowded. There's several conditions that we'll talk about today that happen just simply because everything in the eye is so crammed together that if things change because of side effects, then it creates the snowball and ripple effect. There's a form of immune privilege in the eye. There's just simply a lot to go wrong. So we'll have about 45 minutes to talk. I'll talk for about 45 minutes, and then we'll do about 15 minutes of Q&A. So I can't get to every medication, but we'll get to as many as we can. The chat function, I think, is disabled during this talk, but the Q&A function is enabled. So if you have any questions, put them in the Q&A, and then at the end of the talk, I'll get to them and we'll talk about everything. First topic is hydroxychloroquine. I'll go between the generic names and the trade names, but I'll try and stick to the generic names for most of these medications. Hydroxychloroquine and its mother medication, if you will, chloroquine, is used all over the world for decades for malaria treatment. It is the preferred treatment for lupus right now. And at least where I live in America, it's commonly prescribed for things like rheumatoid arthritis, sarcoid, and other auto-inflammatory conditions. But it creates a toxicity that I think a lot of us know about. It creates a bullseye or a ring-shaped retinopathy around the fovea. And that's been known for years. It's worse with chloroquine, as many of us know, and better with hydroxychloroquine, but it's still not it's still a non-negotiable percentage in terms of retinopathy and hydroxychloroquine. When I started in optometry, not long after this, Michael Marmore and his group at the American Academy of Ophthalmology came out with their recommendations for screening patients who are taking chloroquine and hydroxychloroquine. And I thought it was a great paper. It really changed the way that we saw patients the very next day. We read this article and we realized what should be happening and what should be going on in our patients, and we started to change the way we saw these patients. This article in 2002 focused on the ERG and the visual field, specifically the 10-2 visual field. 9 years later, in 2011, it introduced three things. It introduced the concept of a cumulative dose, which is when the patient reaches 1,000 grams, the risk of retinopathy increases dramatically. And if you're taking the standard dose, this cumulative dose was reached at about 7.5 years or so, if you do the math. It introduced the concept in 2011 of using an ideal weight as opposed to the real weight. And it was for this patient who are perhaps like obese but short, have less of a risk, and then patients who are of, say, a regular weight but taller. And it introduced the novel concept of spectral domain OCT in using OCT to screen for toxicity. And then again, 5 years later, Michael Marmore and his group at AAO revised their revised recommendations yet again and made some more changes. And it went away from using ideal weight. The concept seemed to be confusing for certain clinicians. It leaned more on the OCT, and it added fundus autofluorescence as an important screening tool to use for these patients. And it introduced the concept of patients of different ethnicity can have different sized bullseyes or different sized rings of their toxicity, and specifically mentioned patients of East Asian ethnicity as having like a larger diameter ring, and patients of other ethnicities like a tighter diameter ring around their fovea. So imagine my surprise when I was reading journals last, I think it was a couple months ago, and I found that the group came out with recommendations yet again. And so this article is only a couple months old. And so I wanted to lead off today's talk speaking about it because I think some of our audience might not have read this yet. And I thought, geez, it hasn't been that long since they revised it again, but no, it's been 9 years since they revised it. And if anything, they come out with recommendations every 9 years. So let's dig into what the new recommendations are for hydroxychloroquine screening. The article is broken down into different sections. Each one of these slides will be a different section. The mechanism of action for the nature of toxicity is still not yet known, but we do know that the damage is first to the outer retina and the photoreceptors. As an aside, I'll use my mouse here. There's differences of opinion on what terminology to use when we're describing landmarks on the OCT, but 5 or maybe more than 5 years ago now, a group tried to come up with consensus definitions on nomenclature, and specifically nomenclature for these 4 lines in the outer retina. And so I'll refer to them as these, and I hope everybody else will. I think it's nice to just all be on the same page globally and use the same nomenclature. So this is what we should be using now. That this line is the external limiting membrane. It defines where the neurosensory retina ends. The second line you'll see is the ellipsoid zone, which is the first portion of the photoreceptors. This third line is the interdigitation zone, and of course that's where the photoreceptors interdigitate with the fingers of the RPE. And the fourth line there is the RPE itself. It's labeled RPE Brooks membrane complex, simply because you can't really see the Brooks membrane when it is attached to the RPE. You can only really visualize it on OCT when the RPE is detached from it. And so they just say RPE Brooks membrane complex. So there's these 4 lines, and the first time you'll see damage early on in ethambutol toxicity is to the outer nuclear layer. And you can see at this patient, you skip to the end and you can see what happens after 18 years. But after 15 years, this picture is from the article. Here you can see the outer nuclear layer, this darker band in this color, and it's thinned in this area. And then 1 year later, it's almost completely gone, and you have the interdigitation zone starting to become thinner in this area. You have to admit that it's much thicker and brighter here, hyper-reflective, and then thinner and dimmer in this area. And then after 18 years, which is not that long, this is all within a 3-year period, this patient went from being barely affected to completely gone, and outer retina is gone, photoreceptors are gone, and it's just bare RPE in this area. And so that's what happens with the toxicity. It does nothing, and then it does everything relatively quickly. Patterns of disease, it again goes back to what I mentioned about different ethnicities having different diameter bullseyes. And it identifies, and many more studies have been done in these last 9 years, and identifies patients of Indian, Middle East, and European ethnicity to have a bullseye that it describes as parafoveal. And then it describes as extramacular patients of Northeast and Southeast Asian ethnicity, which will have like a much larger diameter. And we'll show pictures of that, I think, on the next slide. Patients of African ethnicity, unfortunately, have the tightest bullseyes or the closest distribution to the fovea itself. And so theoretically would be the most concerning and the most debilitating. But I think, it's one thing to, if we were in school to memorize this slide and know about like, oh, which ethnicity is which diameter bullseye. But the article, at least this section of the article, ends with this quote: a moderate percentage of patients from each group will show a contrary or mixed pattern. And I think the important takeaway is that it can be any diameter bullseye an astute clinician will just need to know to look for it in general. So don't focus too much on, oh, the patient is this ethnicity, so that I should look for the damage in this area. Just look for it everywhere. Everywhere in the posterior pole, within the arcades, is where you should look for it if your patient's taking hydroxychloroquine. Here's pictures of what it looks like, the parafoveal or the tighter distribution on the left and the larger distribution on the right. Dosage recommendations. It's been known for years or perhaps for decades now that the patient should not go over 5 milligrams per kilogram. And again, that's in real weight. Just know that the typical dose for taking this is 200 milligrams twice a day. And so if your patient weighs more than 80 kilograms or 176 pounds, if they weigh less than that amount and they're taking the standard dose, then your patient is taking too high of a dose. The tricky thing is that they only come in 200 milligram tablets. And so the prescriber will often tell the patient to break it in half. You can see the picture on one of the first slides is those tabs were kind of like barbell shaped, and so they're relatively easy to break. The toxicity is not necessarily like a toxicity over a certain day, but it's over a certain cumulative dose. So you can take like a full dose, say Monday through Thursday, and take a half of a tablet on the rest of the days of the week and be okay. It's more like a cumulative dose in your system. And so that's how they'll do it. But you can tell a patient to skip a dose every Saturday and Sunday, or take half of a dose half the week. But what the patient actually does is a different animal itself. And if we see patients, if you're in the audience seeing patients, you know that patients don't necessarily always do what they're supposed to do. So if you're seeing a patient on Plaquenil, on hydroxychloroquine, don't just assume that they're doing the correct. Ask them what doses they're taking, and they might surprise you about perhaps how high of a dose they are taking. Doses near 6 milligrams per kilogram, quote, markedly accelerate the risk. And there are a couple of one-off case reports of patients taking twice the recommended dosage at 10 milligrams per kilogram, developing toxicity within 2 years. So typically it takes over 10. But I think this is all, like, frankly, a lot of the topics that we're going to talk about today are bummers and make you kind of paranoid that you're going to get these side effects. But whenever I talk to patients on hydroxychloroquine, I tell them it's a very safe drug. If you're using it the correct dose, it's a very safe drug. Of course, there are risks for toxicity, and we're going to monitor for that. But I like this quote, and I've said this to patients, that even after using hydroxychloroquine for 20 years, the incremental risk in the next year of you getting toxicity is still less than 5% if you're taking the proper dose. And so just to kind of like put it in perspective, even if your cumulative dose does exceed that 1,000 grams, it's still very unlikely that you will get toxicity. Risk factors of toxicity, we talked about the dose. Renal disease makes sense, right? It'll increase the circulating level of the drug, almost acting like you're taking a higher dose. Gender is no real risk factor. Liver disease has no risk factor. Tamoxifen use does have a risk factor. Tamoxifen use we won't talk about, but that has a side effect of maculopathy. And what they found is not ring maculopathy, but a different type of maculopathy. But what they found is that these two medications have an adverse metabolic synergy, which is a horrible thing to have. But this kind of like risk factor of two different types of maculopathy creates a higher risk of maculopathy in general. So patients who are taking tamoxifen usually for breast cancer should not take hydroxychloroquine. There's no data to argue that macular disease like age-related macular degeneration or vitelliform macular degeneration would increase your risk of getting hydroxychloroquine toxicity. But still, the American Academy of Ophthalmology advises that it's a contraindication to treatment. And when you're doing baseline screenings for your Plaquenil patients, if they have pre-existing maculopathy, they should be considered for a different medication. The big change that happened in the article from a couple months ago, I think, was how they determined what tests they recommend eye care practitioners use to screen their patients. And they separated the tests, all of our tests, out into primary tests, secondary tests, or not recommended tests. And the only tests that were considered primary are spectral domain OCT and fundus autofluorescence. We've talked about the spectral domain OCT. Fundus autofluorescence, it specifically asks for wide pattern, which would depend on the make and model of your fundus autofluorescence / OCT machine. But you want to make sure you're achieving around a 50 to 55 degree arc of visual field when you're looking for this toxicity, because know that some patients have that really like wide diameter bullseye. And if you're taking just like a tight autofluorescence, you might only hit the middle of that bullseye and miss the actual bullseye itself. So it recommends, the Academy recommends that you do spectral domain OCT on all of your patients with who are on Plaquenil, and you do fundus autofluorescence wide field on all of your patients. If you see unusual things on either of those tests, then you can order a visual field. And it, for the same reasons like we talked about for the wide field autofluorescence, it recommends you do a wide field or a regular field, the 24-2, specifically the 24-2C, because it has these central spots. I was always taught to do 10-2s on these patients, but again, you might miss the wide diameter bullseyes in a 10-2. It also mentions multifocal ERGs as a secondary test. Not recommended is a fundus exam. You might say like, well, why can't I do a fundus exam? It's not like you shouldn't do a fundus exam, but just know that with the naked eye or with the human eye, even with the slit lamp, you're not going to be able to detect changes in the retina like an OCT would or like autofluorescence would. And by the time you can detect it on a fundus exam, it'll have been too late. So the final recommendation and takeaway from this article is that you should do a baseline exam when the patient starts taking the medication. Fundoscopy, OCT, wide field. And then at that baseline exam, look for lupus retinopathy if they're taking it for lupus. Look for pre-existing maculopathy. And then it's an opportunity to educate the patient about, hey, in 5 years, I'm going to start seeing you once a year, and I'm going to do all these tests, and we're going to see each other until you stop taking this medication to make sure you're not suffering from these side effects. And then after 5 years, you start the annual exams, and you do OCT, and you do wide field fundus autofluorescence. That's it for Plaquenil. Next medication, Ethambutol. Ethambutol prescribed worldwide, usually for tuberculosis. It's prescribed for any mycobacterial infection. I think these world maps are interesting, if only because they're almost kind of like negatives of each other. But they're maps indicating where tuberculosis is endemic, and then where something called MAC is endemic, which is mycobacterial avium complex. Again, kind of like the RPE, Brooks membrane complex. They're just calling it MAC as a complex because they're just combining several mycobacterial avium species that can create infections. But they're all infectious by inhalation, and they're all stubborn to treat. And they require months-long therapy just because the infection is so deep in the lungs. Let's talk about how ethambutol can create toxicity. Ethambutol works on these infections because it inhibits an enzyme that's needed in the mycobacterium to build its cell wall. It does so by chelating metals. And when you're chelating metals in the eyes, the metals that you are concerned about are zinc and copper. And so copper is needed in the papillomacular bundle, or the PMB, because that's where our high energy neurons are. That's where the high mitochondria are in all of our neurons there. And if you're starting to chelate copper, you're damaging the mitochondria in those neurons, and you're decreasing the cell function of that. And so typically when you get toxicity from ethambutol, it's a central defect because of the PMB is affected. It also chelates zinc, which can damage lysosomal cell membranes and retinal ganglion cells. So ethambutol creates an optic neuropathy because it's damaging those nerves. But it creates a retrobulbar optic neuropathy, which we'll talk about, I think, in the next slide. The World Health Organization estimates that each year there's 9 million new cases of tuberculosis made worldwide, and half of those patients will be given ethambutol. And so if you estimate a 1 to prevalence of ethambutol optic neuropathy, you're going to get over 100,000 cases of ethambutol optic neuropathy each year, which is a huge number and something that we should be screening for and we should be looking for. The toxicity is dose dependent. You see the risk, percentage risk at certain doses listed here. And you see how it's correlated, the factors that are correlated with better outcome. It's also secreted by the kidneys, so renal disease increases your risk just like hydroxychloroquine does. Ethambutol optic neuropathy, it causes a painless, bilateral, symmetric, and retrobulbar optic neuropathy. I was always told that in retrobulbar optic neuropathy, the phrase is the patient can't see anything and the doctor can't see anything, which is a concerning finding. Typically, when you see optic neuropathy, you're used to looking for a swollen optic nerve head. It's one of those things where it really grabs your attention. But in a retrobulbar optic neuropathy, you really have to go with more of a history. And in a case presentation, you really have to be looking at the medication list in situations like EOM optic neuropathy. This is a classic visual field because, again, it's the PM bundle that's damaged. And so you'll get these central defects, especially defects on the temporal side of the visual field in between the optic nerve and the macula. Patients will have loss of central visual acuity, loss of central visual field, and then color vision problems, again, because it's an optic neuropathy. You won't get an APD typically because APD is almost always measured relative to the other eye. And if you have a bilateral and symmetric optic neuropathy, you won't get a relative APD, but your pupils might be sluggish. And then again, like we talked about, optic nerve swelling is not common. What should we do for patients who are on ethambutol? Because it's such a serious risk and not that uncommon, if we're talking about these percentages of risk that are dose dependent, you need to see these patients at baseline, screen out any patients who already have a pre-existing optic neuropathy, and then see them monthly during the treatment. And each month, you're going to look at their visual acuity, you're going to look at their visual fields, and you're going to look at their color vision at the baseline and then at each month. It also writes the tests that you can do that are not mandatory are the VEP, again, the multifocal ERG. And it urges caution with an OCT simply because it's a retrobulbar condition. And, you know, when you're measuring the optic nerve of the OCT, you're measuring the very anterior part of it, right? And so maybe acutely, you might see a little bit of thickening on the optic nerve OCT. And then chronically, you might see a little bit of thinning. But again, you have a risk of being reassured if you're doing an OCT and finding it normal, that the patient is normal, whereas really there's damaged retrobulbar optic nerve. So use OCT with caution. The only treatment for ethambutol optic neuropathy is discontinuing the medication. Recovery does happen after you discontinue it, but it's referred to as an incomplete recovery. The average improvement is 2 lines better. Something to consider, but that's not proven, is that if your patient is at risk for this, or if your patient is on ethambutol, that the prescribing provider could dose high-dose copper and high-dose zinc. I mean, if the ethambutol chelates, if the toxicity is because of chelation of copper and zinc, then it stands to reason that increasing the dose of copper and zinc would help the patient. But none of that is proven. I think it's just some interesting studies that people have looked at. That's ethambutol. Another very common treatment for tuberculosis is rifampin, part of the most common cocktail given for TB patients. And I saw this picture and I had to add it. I wrote a trivia question. Besides lacrimal system damage, what can cause reddish, orangish tears? I was always thought that like pink, if your patient has pink or red tears, it's a tumor in the lacrimal gland or damage to the lacrimal gland. But if it's reddish orange, it's rifampin. And this happens in 100% of the patients who take rifampin. And I would be very concerned if this happened to me, but it's something that is benign. It goes away 100% of the time. It's never been permanent. And it's just something that hopefully the prescribing provider will tell your patient. But if a patient does come to you saying it, you should be the one to reassure them that it's okay. I also think it's an interesting way to check to see if the patient is compliant. If you're a TV doctor, you try and make the patient cry during your exam, and you can see if they're taking their Rifampin medication. Mechanism is not known. Next topic is erectile dysfunction. These ED meds are some of the most commonly prescribed medicines, bar none, over the whole world. I've listed them here, the three most common ED meds. They work by inhibiting phosphodiesterase type 5, which really, frankly, as eye care professionals, we don't care about. But we do care about phosphodiesterase type 6, which is involved in phototransduction. And I have a picture of that here. So if you're inhibiting PDE type 5, this is found in penile vascular smooth muscle. Inhibiting it decreases the resistance of arteries and it allows engorgement of blood. But inhibiting the type 5 has this weak, admittedly weak, but co-inhibition of PDE6. And so when you accidentally inhibit PDE6, you can have problems with phototransduction and problems with the optic nerve. So a very commonly known side effect to these ED meds is a bluish tint in your vision, which we call cyanopsia. It's long documented that PDE5 inhibitors can cause this symptom, and it's been proven in patients who are actively having this side effect, they underwent ERG studies and have and showed that there was actual changes in the optic nerve while they were having this. But I think it's something that you reassure your patients. I don't think any patient should be contraindicated from taking PDE5 inhibitors because of this cyanopsia. It's very short-lived and has never been found to be permanent. Something that I think patients should be contraindicated to take these medications is if they have certain forms of retinitis pigmentosa. And so there are some types of RP that are caused by mutations in the gene that codes for PDE6. And this would imply that if you inhibit PDE5 for ED, you'll weakly inhibit PDE6, and that'll decrease the retinal function in your patients with RP. And this is shown to be proven in mice studies. It hasn't been proven in human studies. So I would consider telling my RP patients to not take erectile dysfunction medications because of this reason. There's just so much to risk for patients who have RP, sometimes hanging on by a thread, and they don't need any further risk of decrease in retinal function. But by far the most commonly talked about side effect or risk factor with ED meds in the eye is non-arteritic anterior ischemic optic neuropathy, or NAION. And when you read any serious scientific article about NAION and these medications, the word you hear is controversial. And I think I'll try and explain both sides of it here. The main controversy stems from these cases coming out of patients having NAION after taking ED meds, but the simple fact that the risk factors for erectile dysfunction overlap the risk factors for NAION almost completely. So it's really hard to separate out this causal relationship versus just a correlation with these medications. So I'll try and explain both sides. That one of the problems is when you're talking about NAION, we still don't know exactly the cause of NAION, but we do know that nocturnal hypotension plays a role in it, and it stands to reason that most of the time you're taking these PDE5 inhibitors at night. At night, our systemic blood pressure is reduced, and these pills further reduce our blood pressure. So it stands to reason if you're on the border of getting NAION and you take this medication to further lower your systemic blood pressure at night, ergo, you would be a little bit more at risk of having NAION. And there are many case reports, in some case series, of patients who have been diagnosed with NAION within 24 hours of taking one of these medications. But again, the risk factors overlap. But some of these case reports are children who are taking these medications for pulmonary hypertension. And you have to admit that these children don't typically have the risk factors for erectile dysfunction. But all of the studies, all of the papers and articles that are written are all case reports and case series. And you have to admit that this is the lowest form of evidence-based medicine. And none of them explicitly test for an association between the exposure and the outcome. They don't have controls. They're really just case reports. And arguing against a relationship between these medications is the overlapping risk factors that I talked about. And then the sheer fact that there's so many patients who are taking these medications. They are, like I said before, some of the most commonly prescribed medications in the whole world. 6 million prescriptions written for ED meds in the US alone just last year. With all of these patients taking these medications, you have to admit, you would think that you would see a higher incidence of NAION than we do. And so most all studies that look at this conclude that there is no compelling evidence to suggest that PDE5 inhibitors are associated with a higher incidence of NAION. But typically the recommendations that I would give and what I give to my patients is that because NAION can be so serious, if you have a history of NAION in one eye, then I think that's a contraindication to take these medications in general. And then, like we said, if you have a history of retinitis pigmentosa, you should not be taking these medications. But anyone else, frankly, I think there is no real justification for stopping these medications. You should talk to them about the bluish hue in your vision, and that if they have any transient monocular vision loss, to come in right away. But other than that, I would leave it at that. Curiously, I guess I would say almost all of these case reports of NAION have been with Viagra or sildenafil. There have been far fewer in the other medications and none reported with Levitra. Anticholinergics. In America is one of the only countries that has direct-to-consumer advertising that will allow pharmaceutical companies to advertise on television. And almost all of these commercials are half side effects, and they almost always mention glaucoma. And so I think, as eye care providers, we should talk about this risk and this connection, because patients will ask us about this as well. These are anticholinergic medications, so let's talk about the cholinergic system. It uses the neurotransmitter called acetylcholine to control the central and autonomic nervous systems. And so the way it controls the central autonomic nervous system is to generate wakefulness and alertness. So of course, these medications that we're talking about, which inhibit the cholinergic system, cause drowsiness. The autonomic nervous system is responsible for resting and digesting. And so these medications are prescribed for things like bladder and bowel incontinence. There's receptors for the cholinergic receptors all over our body. And so the side effects and the causes and the usefulness of these medications are all over our body also. In the eye, we're really just focusing, though, on the iris sphincter, the ciliary body, and the lacrimal gland. These medications, there's what's the word, mnemonic that you learn in school that you have to think about when prescribing anticholinergics is can't see, can't pee, can't spit, can't poop. The most commonly prescribed anticholinergic in the US is Benadryl, which is diphenhydramine. It's in many allergy medications, again, because it dries you out, can't spit, just kind of like a drying thing, whether it's your eyes or your mouth or your nose. And also, it's in a lot of over-the-counter sleep medications because, again, it decreases your wakefulness or alertness. It makes you drowsy. Oxybutynin is the second most commonly prescribed anticholinergic in America, and that's for typically bladder incontinence. Anticholinergic meds are some of the most commonly prescribed antidepressant medications, too, typically tricyclic antidepressants. These are older, at least in this country. We've switched to a lot of selective serotonin reuptake inhibitors, but still some tricyclic antidepressants are prescribed in patients. Also, SSRIs do have anticholinergic properties, but minimally so. The most of all of the SSRIs, Paxil has the greatest anticholinergic effect. When we're talking about a risk of anticholinergic medications in the eye, typically what we're talking about is this mid-dilation state that these medications can give you. And like we'll talk about in the next slide, this can increase your risk of pupillary block and angle closure. But it's really a very minimal risk. And all we're talking about is inhibiting the iris sphincter, causing it to dilate a little bit and changing the position where the iris hits the lens. And then maybe theoretically causing problems in the outflow of the aqueous humor. So I've put up on this slide the most commonly prescribed antidepressants. On the left is the United States and on the right is the United Kingdom. You can see there's similarities but differences. And then I've placed stars on each of these medications about where you found case reports for pupillary block and where there have been case reports for ciliary body displacement. And you can see for the tricyclic antidepressants, it's typically pupillary block. And for the SSRIs and the SNRIs, it's typically ciliary body displacement. So let's talk about each of those. There's two different mechanisms of action where these meds can cause problems with angle closure. The picture on the left is a picture describing pupillary block in closed angle glaucoma. And again, we talked about in anticholinergic medications, you're slightly dilating the pupil, and it could stand to reason that in a patient who has pre-existing narrow angles, you moving or the drug moving the position of the iris could cause problems. A lot of us on the call know that the position of the iris that is the most risk of creating angle closure is this mid-dilated position, where the tip of the iris has the strongest contact, I should say, with the most anterior part of the lens. And so if you have a patient with a really thick lens in a cataract, and you put that edge of the iris right at that mid-dilated spot, you could create an adhesion of the iris to the lens, creating a backup of the aqueous humor, creating iris bombée, and then closing the angle, like we all know about. The mechanism, this is exceedingly, vanishingly low risk factor in anticholinergic medications. And the sheer volume of patients taking Benadryl and taking anticholinergic medicines for whatever reason, and the sheer lack of angle closure that we see just shows that it's a theoretical risk and not a real risk. But I think what a real risk is some of these medications that have choroidal effusion or uveal effusion, creating narrow angles and angle closure. And that's a completely different mechanism of action. Here, the picture on the right shows a normal flow of aqueous humor. And the picture on the left shows a topiramate-induced choroidal effusion and angle closure. And what's happening here, what the artist is trying to illustrate, is a swelling of the ciliary body. And when it swells, it pushes it centrad and then anterior also. And this pushes the lens anterior, which pushes it into the iris and pushes the iris anterior into the cornea, closing the angle and then creating an angle closure. When you treat the first type, when you treat pupillary block, the solution is very easy. You just equalize the pressure between the anterior chamber and the posterior chamber. And the easiest way to do that is to blast a hole in the iris with a laser. You do an LPI and the problem is solved. If you do an LPI in uveal effusion, you're not going to solve anything because it's not the pressure differential that's creating the problem. It's simply the anatomy of the ciliary body being too swollen and lifting up anteriorly and closing everything. So a laser is not going to help it. The only thing that can help it in this situation is to stop the offending agent. And again, it behooves you to look at the patient's systemic medications. If a patient comes in what looks like angle closure, you're going to start the process of lowering the pressure and getting the patient an LPI to relieve that. But if you don't take a couple of seconds and look at the med list, you're going to maybe miss the fact that this patient is on topiramate or this patient is on a high-dose anticholinergic medication, and that the cause is not necessarily pupillary block, but the cause is choroidal effusion. So what do you do in cases of uveal effusion? You stop the offending agent, like I talked about. You give IOP drops like you would in angle closure. You give steroids because steroids act to shrink the ciliary body, which then lets the whole lens iris diaphragm shift back posteriorly. And you give cycloplegics, not to block any kind of synechia, but just because cycloplegics have the same effect of rotating the lens iris diaphragm posteriorly. And remember, when you're giving IOP medications, remember the pilocarpine paradox is that pilocarpine is a cholinergic type of medicine. So you would imagine that if you have an anticholinergic problem, you should give pilocarpine. It'll shrink the pupil. But pilocarpine has this kind of like paradoxical effect of causing the ciliary body to shift anteriorly. So stay away from pilocarpine in these cases. There are several case reports of this. I've seen cases of topiramate-induced angle closure. There are cases of Lexapro-induced uveal effusion. The first one there is an SSRI. Sumatriptan and topiramate are often prescribed for migraines, and you'll see this a lot. Topiramate is the highest risk factor of all of these medications to cause uveal effusion. Topiramate is the tops, but sumatriptan is not far behind. I'm going to skip this slide, and we're going to go into our next and last medication, acne medications. There's two meds that I wanted to talk about. The first one is doxycycline. Doxy is used all over the body, frankly. I use it in my patients for ocular rosacea often, but it's also worldwide the most common oral medication used for inflammatory acne. It works by decreasing the bacterial load in skin follicles. But its side effects are something that we should know if we're prescribing it, for inflammatory acne, but if we're prescribing it for ocular rosacea or meibomian gland dystrophy, and that it causes what can be somewhat severe sun sensitivity. So I mentioned how it's snowing here in Boston. This is the perfect time to prescribe doxycycline for your patients, where the risk of sunlight and sunburn and sun damage is less. If you are prescribing doxycycline and the patient's about to go on holiday to a beach vacation, or it's the summer months where you live, tell them about the risk of sun damage, sunburns, and then therefore skin cancer. Tell them to, while they're on it, to stay out of the sun as best they can, or wear a high level of SPF sunscreen. Doxycycline also causes nausea, so you tell your patients to take it with food. And it's contraindicated in children, causes staining of the teeth. But the real acne medication that I wanted to talk about was Accutane, or isotretinoin. This is the most commonly prescribed oral med for severe or cystic acne, and it works by reducing the content of sebaceous glands, or the production of sebum. But it has a massive amount of side effects. It's strictly contraindicated in pregnancy for the risk of birth defects. It raises your triglycerides, causes bone toxicity, problems with your skin, problems with your eyes. Like a lot of the medications we've talked about, it's dose dependent. The most common dose is 0.5 milligram per kilogram per day. And you're supposed to stop the medication when you reach a cumulative dose of 120 milligrams per kilogram. If you are, for whatever reason, taking 1 milligram per kilogram, you have a 98% risk of experiencing some kind of side effects. And if you're taking a low dose, even if you're taking a low dose, you have a non-insignificant chance of getting side effects. It works, I think, really well for acne, but it just causes a lot of side effects. So let's talk about the ocular side effects. I have here a picture. Take a look at this picture. In your rod photo receptors, there are rhodopsins, and in our cone photoreceptors, there are coneopsins. I'll walk you through this. Isotretinoin can cause night blindness and color vision problems. The way it does so is that in our rods, we need rhodopsin for phototransduction. Retinol is crucial to make rhodopsin, and isotretinoin inhibits the synthesis of retinol. Rhodopsin is a protein. The Rett in isotretinoin is related to retinol, which is just vitamin A, essentially, right? So if your patients are on Accutane, ask them about this. And if they're experiencing this, you might talk to the prescribing provider about decreasing the dose of this because it can be serious. On the ocular surface, it probably has the most side effects because what it works by decreasing sebum on the skin, right? But what are meibomian glands if not just large sebaceous glands? And so at a typical dose or at a dose of 0.8 milligrams per kilogram, 66% of patients will develop dry eye. And it's simply because their tear film evaporates more because they don't have the oil layer of the meibomian glands. But it's not just a typical evaporative dry eye complaints that you can supplement. You'll get a decrease in corneal sensitivity if it's severe enough, and a decrease in the diameter and density of the subbasilar neural plexus that I have in a picture here. And they can be long-term side effects. When you lose the diameter and density of your subbasilar neural plexus of the cornea, these can be permanent side effects, just like you might see in exposure to pepper spray. Consider this like pepper spray to the eye. What do? You can stop the treatment if the symptoms are too severe. But every patient who's on isotretinoin should take artificial tears. And you might consider omega-3 fatty acids to aid meibomian gland secretion. And you should screen out patients with corneal disease. Anyone with any corneal disease should not be taking this medication, especially things like corneal transplant. That's the last slide. In conclusion, I mentioned this several times during the talk, but we're all very busy. Some of us see a ton of patients each day, and it's very easy, I think, to give the patient an eye exam, focus on glasses, focus on vision, and then move on to the next patient, and not take the time to click on their medication list or really look at their medication list. And again, so many medications have side effects, and so many of those medications have side effects in the eyes, but you're not going to remember all of them. But I think the more you attend lectures like this, the more you read about ocular side effects, the more it's going to stick in. And maybe you won't remember everything about what I said today, but you'll remember those meds, and those meds that he mentioned have some kind of side effect. Let me look them up. Don't be afraid to look up medication side effects in front of the patient. I don't think the patient expects us to know every side effect of every medication that's ever prescribed in the world. I think that the patient would be thankful that you're taking the time to check to make sure they're okay. Even if your patient isn't experiencing symptoms, verbalize to them the symptoms to look out for, and so that if and when they do start to experience those side effects, they come in sooner rather than later, and you can catch it sooner. And then when in doubt, especially if you're a new clinician, and this is true, I think, for anything, side effects or anything, if you're ever in doubt of something, if you're on the fence, is this a side effect? Is it not? Is this disease or is it something else? Just bring the patient back sooner. Make a decision one way or the other, but if you're not confident on it, just bring the patient back. Never be afraid. Okay, first question from Fathi. What are the most common ocular side effects associated with oral medications? How can oral medications affect the eyes? What's the important eye care professionals to review a patient's medication history? And are ocular side effects from oral medications reversible? Good questions. I like to think that I answered all of those questions. And in fact, some of these questions there's just so many ocular side effects to oral medications, right? Like I said before, like I can't talk about all of them in 45 minutes, but I like to think that I talked about a decent amount of them. Okay, next question from the same person. How can corticosteroids cause ocular complications? Early detection, ocular side effects. I'll talk about the first one about corticosteroids. I didn't mention corticosteroids, but obviously corticosteroids have tons of ocular side effects. The reason I didn't mention it was simply because that's pretty well studied. I didn't find anything new or interesting about it. But to answer your question, the two big side effects that you can have with oral steroids are cataracts and glaucoma. Steroids can cause people's intraocular pressure to increase when they're on them. And so your risk factor for glaucoma is high. It doesn't do it immediately. Some of these medications we talked about today have immediate side effects. steroids take at least several weeks to raise your intraocular pressure. And the same thing for cataracts. You're not going to immediately get cataracts if you take steroids for a month or something like that. But if you're on long dose steroids, your risk of certain types of cataracts increase. This question at 9:09 was from Pablo Almiron. He says, sorry, I'm trying to read the questions, but they keep changing. What are the long-term effects of eye drops using dexamethasone and tobramycin? It's a good question. Tobramycin is an antibiotic and dexamethasone is a steroid. Tobramycin really has very little side effects. If anything, maybe a drying out of the ocular surface, but it's pretty minimal. Dexamethasone is a steroid, and so that would just be the same answer as I gave before for oral steroids. High risk of, I shouldn't say high risk of glaucoma, but a risk of increasing your intraocular pressure and then causing glaucoma if you're on dexamethasone. Dexamethasone and tobramycin is one of the more commonly prescribed eye drops in the world, I think. It goes by the trade name Tobradex. It's a nice combination, antibiotic and steroid, to give to patients with red eyes. And I would feel very comfortable. I've prescribed Tobradex all the time, and I don't really worry about the patient having glaucoma. But if I'm prescribing it for more than a month, I'll bring the patient back and just keep working them up to make sure I'm not causing their intraocular pressure to increase. At 9:10, Tahir Sabir says, blurring of vision or change in refraction after the use of antidepressants. Kindly discuss. I'd like to think that I did answer that question, so I was fortuitous in that. Blurring of vision, changing of the refraction with antidepressants has to do with changing the dilation of the iris sphincter, which, just like when your pupils are dilated, can blur your vision. And then the refraction can change when you cause that anterior shift in the lens iris diaphragm can create myopia. And so this large shift in refractive error, this large myopic change in drugs like topiramate it can be common. How to screen for this question is from Dan Maya at 9:23 in the morning. I shouldn't say the time because we're all in different time zones. How to screen for ethambutol toxicity in pre-verbal children? Excellent question, because things like color vision and things like performing a visual field might not work. Perhaps you could get a visual field on a pre-verbal child, but probably not. Visual acuity you can get on a pre-verbal child, but whenever you have a patient like this, whether it's a child or an adult, there's someone who you just can't communicate with, your objective tests are the best bet. And things like pupils would be very important here. So I mentioned in ethambutol toxicity that you'll see sluggish pupils. You don't look for an APD in pupils, but you see sluggish pupils. A child should have very brisk light reflex in their pupils. So if you see a patient who perhaps the mom thinks they've been acting strange and now suddenly their pupils are sluggish and they're on ethambutol, that's a very strong risk factor for that. How to eliminate ethambutol toxicity from Abul Qazi. The only way to eliminate it is to stop the ethambutol and then just hope that it comes back. A question from Anonymous. How would you differentiate ethambutol or toxicity in diabetic patients receiving anti-VEGF for diabetic macular edema? How do we monitor? What advice should be given? It's an excellent question, but they're two very different things. Diabetic patients can get macular edema, like you talked about, and they can get these injections, but that's in the macula, and ethambutol toxicity is in the optic nerve, and so you just look in different spots for them. This question is from Soviana. I recently had a lot of cataract patients with benign prostate hypertrophy. I suspect one of the prostate meds is causing it. Any thoughts? I do not think that any of the BPH medications have much of a risk of cataracts. I think, again, like we talked about in some of these cases, they're really overlapping conditions. Who gets BPH? Usually older men. Who gets cataracts? Usually older people. And I would just probably leave it at that. Of course, there's lots of different ways to treat prostate problems, and so maybe one of them is steroids. And steroids are associated with increased cataracts. But I think in general, there's not much connection between those medications. This question is from Shefa. Are there any, I lost it again. Are there any ocular side effects from hypertensive medications? Geez, there's so many hypertensive medications. I'm having to scroll through them in my brain. My 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 number one answer is no, with the caveat that if you decrease the blood pressure too much or too quickly, you can have problems. You can have problems in the optic nerve and create, like I talked about in the erectile dysfunction medication, a NAION, ischemic optic neuropathy, if the pressure goes too low. So I'll say hypertension or antihypertensive medications are perfectly safe in the eye unless the blood pressure drops too low. I'm going to start from the bottom and read these questions because it's easier for me to scroll up from the bottoms. This question is from Ankita. Do contact lenses also pose some side effects in the eyes? Sure, tons of side effects. You know, if you think about a contact lens, it's simply just a piece of plastic that you put over your cornea. The cornea doesn't have any blood vessels in it, and so it gets its oxygen from the atmosphere. But if you put a piece of plastic over it, it's severely decreasing the amount of oxygen that your cornea gets. So the complications from contact lenses are typically dryness, but then also neovascularization because the cornea is being a little starved of oxygen. Tanmaya asks, any role of VEP in ethambutol toxicity in screening preverbal children? That's a great question. You probably mentioned that as I was saying it, and that's an excellent question. I will admit I don't have a lot of experience with VEP or multifocal ERG, but those are tests that are objective tests that the patient just has to sit there. As long as they can sit there and behave, you could do VEP or multifocal ERG on those cases. That's a great point, Tanmaya. I'm scrolling through this question. Oops, I just lost it again. Sorry, it's frustrating. I'm starting to read it and then it disappears. This question is from Chidi Aberi. I'm sorry if I mispronounced that. What roles do doxycycline play in the treatment of long-standing chalazion, especially in patients who do not want to undergo surgery? This is a great question, and I'll answer it two different ways. I prescribe doxycycline to patients who have hordeola and lid problems all the time. Again, the role of doxycycline in these patients is to decrease the bacterial component on the ocular surface in the eyelids. And it's the bacteria that are getting inside these meibomian glands, creating an infection and then creating an acute hordeola. And so theoretically, you know, if you can decrease the bacterial load, you can decrease what's inflaming the meibomian gland. And you can decrease the risk and incidence of hordeola. You mentioned long-standing chalazion, though, and that's a different subject because once a hordeolum is no longer acutely inflamed, it becomes hard and becomes calcified and becomes a chalazion. And then it's not really about an infection. It's not really about bacteria. It's just about this almost like scar tissue that's stuck in the meibomian gland in the eyelid. And really the only way to get it out is time and hope it gets better on its own, or surgery. But decreasing the bacterial load in that situation is not really going to help anything. This question is from Anonymous, is when do we as ophthalmologists intervene and suggest dose changes of medication, especially in macular risk? I think this is a fantastic question. I think you should never hesitate to advocate for your patient. And there's so many specialties in medicine, but one of the things that I like the most about eye care is that nobody really knows much about the eye. And if you flip that question a different way, everybody in medicine is relying on you to tell them what to do about the eye. And everybody in medicine, from podiatry to dentists to infectious disease to primary care physicians, all care very much about the vision, and they don't want their patient to go blind. It's one thing if the patient has acid reflux or if they have cavities or something like that, but if they're losing their vision, if a medication that a dentist is prescribing and is causing someone to lose their vision, I would take that extremely seriously. And so your question about when should we be changing the dose, I would recommend never hesitate to call, write, depending on how the urgency of the situation, but speak to the provider who's prescribing the medication to the patient and tell them what you see, and tell them, especially if it's macular disease, like you write in the question, about the urgency and the risk of serious vision loss happening to this patient. And I would imagine that prescribing provider will be the first to say, like, okay, let me find some other medication to use because I don't want to risk this side effect of happening. And so the thing that I would urge all of you is to empower you to say that you know the best about the eye and you have the best interest, your patient's best interest in heart, and just speak up. I think if anyone came to you with a question about the eye, you would be very happy to answer for the patient, and very helpful. You want to be as helpful as possible to the doctor and to the patient. And you should do the same thing um, as an eye doctor. Never hesitate to advocate for your patient and to reach out. It takes a little bit longer to make a phone call or to send an email, but I think it's very worth it, and our patients need us to do that. All right, it's past 10, so I should probably let everybody go, but I really appreciate being asked to speak to the group. I enjoy these, and I hope you enjoyed it too. So thank you.